Has started.
Thank you. And hello, everyone. And thank you so much for joining today's webinar on how asthma can mask rare lung diseases. My name is Nicole Goldsboro, and I will serve as your moderator for today. We have a full agenda, but before we get started, I would like to review a few housekeeping items. Today's presentation is in listen-only mode. This webinar will be recorded, and you can play the webinar back at any time using the same link you used to join the webinar today. You will also receive a follow-up email with the recording and additional resources and information from the American Lung Association. During the webinar, if you are having difficulty accessing the presentation, there are a few things you can try. If you have difficulty hearing the presentation, first, you can check the volume setting on your computer or your device. If you still have trouble or cannot see the slides, you can try to refresh to the web page or log out and log back in using the same link you received to access the presentation. And as a reminder, we encourage everyone to consult their healthcare provider with any questions you have regarding your specific medical condition. The American Lung Association's mission is to save lives by improving lung health and preventing lung disease. And our vision is a world free of lung disease. Today's webinar is made possible through the generous support of Savera, AstraZeneca, and GSK. And now I would like to introduce our guest speaker, Dr. Sanober Kable. Dr. Kable is a board-certified pulmonologist and critical care physician. She is currently the director of Premier Pulmonary Critical Care and Sleep Medicine in Texas. In addition to her role at Premier, she is on staff as a physician at numerous locations throughout Texas and an adjunct clinical assistant professor in the Department of Internal Medicine and Geriatric Medicine at the University of North Texas Health Science Center. Dr. Kable is a board member of the American Lung Association in Texas and is involved in improving patient care by engaging in multiple research projects as well as providing care in underserved communities throughout Texas. Her areas of interest include interstitial lung disease, pulmonary hypertension, asthma, COPD, and NTM lung infections. Not only is Dr. Kable passionate about lung health, but she enjoys spending her time with her husband and kids. She's an avid reader and loves reading fiction. She enjoys long walks and loves to travel the world. Dr. Kable, it is an honor to have you join us, and I will turn the presentation over to you.
Thank you so much for the kind introduction. Hello, everyone. My goal today is going to be to make it as easy, as informative as possible. Just take this as a generalized idea on how asthma can mask rare diseases. However, do discuss it with your pulmonologist or your primary care physician so that you have a good understanding of what you hear today. And not everyone is going to have a rare disease, but just because a lot of the time we get, especially as physicians, when we have so many patients, we get hooked on just common lung diseases and may not be looking into the rare lung diseases sometimes. And there may be many reasons for that. And we'll discuss that further, why this happens for many of the patients. So here you see the picture of the lung, and it has a mask on. It is just to depict how rare diseases could be hiding under the common lung diseases. So today's agenda, we're going to talk about just types of lung diseases. We're going to talk about symptoms of rare and chronic lung diseases, diagnosing, how do we diagnose lung disease, how do we unmask the rare lung disease, and then we'll go over some of the resources and Q&A at the end. Again, another disclaimer, always consult with your healthcare provider with any questions you have regarding your specific medical condition. Of course, we'll have a Q&A session at the end, but definitely we can't get to know you in this little webinar at this point. Of course, our mission is to save lives by improving lung health and preventing lung disease. American Lung Association has done tremendous work by educating people, by raising awareness, and so I'm very proud to be part of the American Lung Association, and I'm very thankful that I have this opportunity to educate so many of you today. Of course, thanks for our webinar sponsors, AstraZeneca, GSK, and Severa. And this is me. So let's go over the types of the lung diseases. This is a great video. We'll start with that, and then we'll go further.
Dr. Kable, do you mind quickly taking control of the slides?
Yeah, of course.
Great, thank you so much.
Yep. Okay, so were you guys able to see the previous slides or no?
We did,
Yep.
yes.
Did. Okay, perfect. So I'll just kind of play this video that is going to kind of go over just a generalized idea of the whole picture. Okay, so you all got to hear about there are three main categories we're going to talk about: obstructive lung disease, restrictive lung disease, and vascular diseases that affect the circulation within the lung. Now talking about the rare diseases such as eosinophilic granulomatosis with polyangiitis, which is EGPA, autoimmune pulmonary alveolar proteinosis, which is aPAP, or pulmonary arterial hypertension. So they will be considered rare lung diseases. So we'll quickly go through a case. This is Sarah. In December of 2022, Sarah went to see her primary care physician. She was short of breath, and she was diagnosed with acute bronchitis, and she was given some medications to treat her condition. Let's see. Okay, so most common symptoms of pulmonary diseases are going to be patients going to come in short of breath, there's coughing, they're tired, they have recurrent infections. Sometimes there's weight loss going on. Sometimes they have chest pain or pressure. So all of these symptoms, even for common and rare diseases, can overlap with each other. Now, going over the four categories here, one is asthma, which is very common. I think a lot of us know someone that had asthma. It's an obstructive lung disease. It can be used or diagnosed by using spirometry. Simple test, you kind of breathe in, blow into it. It's typically a computer that's attached to, or there might be a booth where the spirometry can be done, and we can tell the patient has obstructive lung disease. On the other hand, EGPA is rare. It's an immune disease that causes inflammation in the small blood vessels due to high levels of eosinophils, leading to granuloma formation. Granulomas are collection of these cells that are present when we do a biopsy on patients that have these raised lesions in the lung, nose, sinuses, skin, wherever they might show themselves. Mostly in the lungs, however, nasal passages, sinuses, skin can also be involved. If your physician or nurse practitioner or PA suspects there might be EGPA, they'll order some blood tests. That is to check for eosinophils, and some imaging results, and a biopsy may be needed to confirm EGPA diagnosis. And then going over to the aPAP, which is the autoimmune pulmonary alveolar proteinosis, is extremely rare. It basically leads to a buildup of surfactant in the air sacs of the lungs, making breathing more difficult. We all need surfactant to keep our alveoli open, but when there is an excess of that surfactant, the protein that lines our alveoli, that leads to reduction in gas transfer, basically. When anything of too much of that, too much of good, basically leads to aPAP. And then if a physician or nurse practitioner PA suspects there might be aPAP, they'll order a simple blood test. Of course, typically we do a CT scan of the chest, and we see a specific pattern called crazy paving. Then we suspect that there might be, aPAP going on. At that point, we order the blood test for the patient. And then coming over to pulmonary arterial hypertension, it is rare. It is caused when the blood vessels in your lung, especially the pulmonary artery, and the smallest branches of the pulmonary artery, when they become thick and narrow, is going to lead to increased pressure in the pulmonary artery, the blood vessel that supplies your lung, and that's going to lead to a high pressure in the right side of the heart. Again, if you suspect that you have pulmonary hypertension, we start with an ultrasound of the heart, or in the other words called echocardiogram. And if that shows that pressure is high on the right side of the heart, then we will do what we call a right heart catheterization, which can be done by a pulmonologist or by a cardiologist. So this is kind of summary comparing asthma, which is a common lung disease, to three of the rare lung diseases that we're talking about today. Now, as we said, the symptoms can be so overlapping that, again, on the far left, you have the signs and symptoms. On the right, you have asthma, then EGPA, then aPAP, then PAH. Shortness of breath, if you see, is present in all four of them. Chest tightness, except for aPAP, is present in most of these diseases, rare and common both. Cough, again, it's present in most of them. Pulmonary hypertension, typically we don't see as much cough, but it can happen. Wheezing, again, both asthma and EGPA, we can hear wheezing in these patients. So again, makes it pretty hard for even experienced physicians that see common lung diseases or other common diseases to differentiate. Unless you treat a lot of this, you may miss it. Again, further looking into asthma and the other rare diseases, when you look at the organ involvement, like for example, for asthma, you'll see most symptoms are related to the lungs. They're short of breath, they're wheezing, they're coughing. On the other hand, with EGPA, you see other system involvement, such as skin, nasal passages. You may have even other symptoms of neuropathy or abdominal pain and others. So EGPA is kind of like a systemic disease, or systemic symptoms are present. aPAP also is more specific to the lung because the surfactant that lines the alveoli is in more abundance than it should be. So it's more of a pulmonary disease as well. not systemic. And pulmonary arterial hypertension, no other organ involvement directly, but indirectly we do see some swelling, such as it mentions in the other symptoms. When we listen to the lungs, or when the patient describes the symptoms of the lung sounds, they'll say, "Oh, I whistle when I'm breathing out." The same is true for EGPA. That can happen with EGPA as well. On the other hand, aPAP, we hear some crackles. It's almost like having a paper, and when you crumble it and there's a crackling noise, that's what we hear with aPAP. PH symptoms vary depending on how much, if there's any associated pulmonary edema or any other lung disease with it. And now going over to the cough, mostly with asthma, we hear a dry cough. However, depending on how much inflammation is there, there might be sputum production. EGPA, again, mostly not. However, if there is underlying asthma with EGPA, then that we could hear some wheezing and stuff or coughing. aPAP, we do have some dry cough, minimally productive, because most of that is obstructing the alveoli. With PAH, there could be some dry cough, depending on the again how much, if there is pulmonary edema or there's any other reasons for PAH. Now, the other thing I would look at would be eosinophils. So typically with EGPA, we're going to see high amount of eosinophils, more than 5% of eosinophils. So looking at eosinophils, they're part of our white blood cells. We all have eosinophils. They help us fight parasitic infections, but when they are in too much count or too many of them, they can start affecting lungs and sinuses and the skin and all the other organs, such as we see in EGPA. Usually we see them in thousands in EGPA. On the other hand, with asthma, there is something called e-asthma or eosinophilic asthma, where we're going to see that eosinophils are elevated, but they're not as high as we see in EGPA. So those are the, again, two things where we have to kind of pay attention a little more. In aPAP, patients usually have bluish skin or fingernails, again, because of lack of oxygen, because there's a lot more surfactant in the alveoli. Gas exchange is poor. There's lack of oxygen, and they'll look more bluish. Pulmonary hypertension, again, we can see bluishness as well sometimes if there's oxygen transfer has been affected too much. But most of the time, patients will say, my legs are swollen, my abdomen is swollen, I'm dizzy. They may have chest pains. It's almost like symptoms of heart disease. And that's why a lot of these patients end up seeing cardiologists. And there's usually a delay in seeing a specialist that treat pulmonary hypertension of an average of about 2.5 to 3 years for pulmonary hypertension patients. Because we all think when there's chest pain and there's swelling, it possibly is more cardiac than anything else, which pulmonary arterial hypertension is affecting the right side of the heart. So in the end, there is a link, but it is a unique condition. Okay, so looking at Sarah again, so in 2022, she had first developed symptoms. She was given medications to treat acute bronchitis. And then in March of 2023, which is about 4 months later, she goes back to her provider. She's still more short of breath. They do the spirometry, they diagnose her with asthma, and she gets treated for asthma. She comes back again about 4 months later, and then she's continuing to have shortness of breath. She's symptomatic. She goes to ER with asthma attack, and she's not improving. So that is clearly a sign that either the diagnosis is wrong, right, or the treatment is not adequate. So that's where you start thinking, like, what's going on? The wheel should start turning. There's something that we are missing here as physicians, as well as patients being their own advocates. Now for her asthma action plan, they give her what medication she should take when she's feeling fine, what she should take when she's kind of in the orange zone, and when she's in the red zone, where she should typically go to the ER when you're in the red zone. And so she does good asthma management. She's taking her medications properly, being active and following the plan. And then so now we are coming back to the data, like how do we detect chronic lung diseases that are rare earlier. What could we do to do early detection? So first and foremost, physical examination from physician standpoint or a provider standpoint is extremely important because sometimes just the physical exam can tell us a lot more about that patient or a lot more about that disease state. The second step, typically depending on the patient presentation, could be imaging, such as X-rays or CAT scans of the lung, followed by a blood gas analysis or CBC with differential, where we look at the eosinophil count, lung function testing, such as spirometry, which tells us about obstructive lung disease, more so. The full lung function testing is needed for the restrictive lung disease in most cases. A 6-minute walk test, which is where we walk you for 6 minutes. We see what your heart rate does, what your oxygen does, and is that an adequate response for your age group or inadequate? And that can also give us a lot more clues about where to look. And then lastly, echocardiogram, just to make sure there's no pulmonary vascular issue going on the right side of the heart, and the valves are okay, and there's, the shortness of breath is not coming from a cardiac reason. Um, and I think most of you will question, or even as physicians, we always look back and say, hey, what could we have done to diagnose the disease early? And so most of the time, I think some of this is because symptoms are so vague. There's so many overlap in the symptoms that you really could initially delay the diagnosis just because you're thinking anybody that walks in is not going to have a rare disease. So you're looking for common diseases first. Number two, there's specialized testing involved. Not everybody knows how to kind of read a CT scan or echocardiogram or spirometry. So a lot of the time for rare disease, you're going to need a specialized person that would dig in more than just the common disorders. And again, the last point is the same, that the regular physician that you see may not have as much exposure to the rare disease. If you don't see it, you're not going to suspect it. And so there's some limitations. Some are conscious and some are unconscious limitations that we have. But yeah, a lot of the time, if you feel like you're not improving, and there might be, some issues there that need to be seen by a specialist, be an advocate for yourself. Okay, so let's go dig in a little bit about the aPAP. So it's really in less than 5,000 people in United States, right? So very small number of patients. So not very common, not many pulmonologists or primary care physicians have seen this or recognize this. And then again, we may dismiss your symptoms saying, well, yeah, you're short of breath, you have asthma, and we may, as physicians, we may dismiss your symptoms. And it, again, resembles more like common lung disease, initially diagnosed as asthma or pneumonia. And then, again, a lot of the healthcare providers are unfamiliar or don't know what test to order. There's a simple blood test that can be sent for aPAP. Okay, so I think I'm going to kind of repeat ourselves again that maybe physicians may not be aware of the testing procedure for the specific disease, and the disease that is being diagnosed. It is by ruling out other common lung diseases. Some of the test results could mimic common lung diseases. Spirometry, the test that you do in the office, not everybody knows how to correctly read it, even though they may be performing it. And that could also happen if they don't have a lot of exposure or they don't have time to read it properly. And then, some clues in the diagnostic tests are not clear to the physician that's unfamiliar with the rare disease. So again, vague unfamiliarity with the test results or not properly kind of evaluating the test results could be a reason. For EGPA, what is needed, right? The question is, if someone has EGPA, if you suspect EGPA, what are we needing? First step is going to be CBC with differential. Most of us, when you go to primary care physician, that's a yearly test that we do a CBC. What we don't see sometimes is a CBC with differential. What CBC look for, complete blood count CBC stands for complete blood count. Looks for is your white blood cells, your hemoglobin, and your platelets. And in essence, that's what we're looking for. And then in the white blood cells, we all have neutrophils, basophils, eosinophils. So when we say we do a CBC with differential, we're specifically trying to see how many eosinophils do you have, how many basophils do you have, how many neutrophils do you have. So if the eosinophil percentage in that CBC is more than 5% of the total white blood cell count, that would raise concerns for EGPA in the right patient. In some patients, we see if the kidneys are affected, we see that urine analysis could show some red blood cells or some protein in the urine, and then definitely needing a chest X-ray or preferably a CT scan of the chest to detect abnormalities in the lungs, or CT of the sinuses to detect abnormality in the sinuses, because typically EGPA symptoms do start with adult onset asthma, then we see sinus issues, then we see skin issues start happening, and then urine and neuropathy and abdominal symptoms can also happen with EGPA. So for aPAP, simply we typically start with a CAT scan. We're going to see something called a crazy paving pattern in the lungs, and then we proceed with a blood draw, which is looking for antibodies that your body might be making against a protein called GM-CSF. Another blood test that's available is called aPAP ClearPath test that can also determine if you have aPAP. Now, how to recognize from your standpoint to see when a treatment is not working. One, look at the specific pattern of your symptoms. You will know what started and how it's progressing or not improving. And so if the symptoms are not improving with current regimen, then you may want to ask for a specialized care or be referred to a specialist. Also, if you realize that some of your symptoms could be coming from a different lung disease, that may also prompt you to ask your physician to refer to a specialist. Again, examples we've gone over are EGPA and aPAP. With rare lung disease, sometimes we do see that there's family history. Not all the time, but sometimes we're going to see, pulmonary hypertension can run in the family called familial pulmonary hypertension. We see a lot of eosinophilic issues in the family where we're going to see more asthma or late onset asthma in some cases. So yeah, if there's a family history, please tell your provider or to kind of dig into it. Detailed medical and occupational history is important. Many times you find, the patients don't report it to us, that they had worked in, around silica dust or around chickens that can cause histoplasmosis, or they've been certain part of the world or US even. Travel history is important, or even exposure to animals at home. Sometimes birds can cause some of the chronic lung diseases. So we want to know anything and everything about your history. And then, of course, utilizing specialized testing, which typically you're going to need a physician order, is looking for the blood testing, the CT scan of the lung or the sinuses, right heart catheterization, or bronchoscopy or biopsy if needed in some cases. Definitely consulting with a specialist is very important. And then going back to Sarah, which is our patient that we've been following. So she, as you mentioned before, December 22, her symptoms started. Then March 2023, she gets diagnosed with asthma. Then July of 2023, she's continuing to have problems. She's going to the ER. September 2023, she actually gets referred to a pulmonary specialist, which is about 10 months from the initial symptoms that she started with. And that's where she gets specialized testing. She gets an X-ray ordered and a CAT scan ordered. And based on the CT scan of the chest, she gets the blood draw sent for GM-CSF antibodies. And that's where she gets diagnosed with aPAP. So it really takes her about 10 months to get a diagnosis. Now, how do we unmask the rare lung diseases, right? How do we make it more accessible for patients? How do we prevent the delay in diagnosis? So one, educating healthcare providers more about the rare lung diseases as opposed to focusing on common lung diseases. Um, Sharing your history if you have a rare lung disease and you went through so much with your diagnosis, sharing your history with your not only the healthcare provider, your family members, so they can also be on lookout for that, also be helpful for other patients. Also alerting your healthcare provider if you have unresolved symptoms with current treatment. So don't think, well, I'm going to bother my physician or they don't have time for me, they're too busy. I think just making sure that you are utilizing your portals. Some of you may have physicians that you see that portal access, or if any way that you can you have access to the healthcare provider, you want to make sure you let them know about your symptoms, about your concerns, because that might help them recognize it a little bit quicker or get you specialty care a little bit quicker. Asking for a second opinion, very important. If you feel like, hey, I am not getting the answers that I need, ask for a second opinion. Self-advocate or advocate for a loved one. So if you know someone that is not getting care or not improving, please advocate for them and definitely get support. And there's a lot of support out there. We will share some resources for you as well, so you kind of know where to go if you have any questions. So the key takeaways from today's talk will be: one is alerting your healthcare provider if your symptoms aren't improving, making sure that you have given detailed medical and family history. Sometimes even writing it down is important, because sometimes I've seen that patients come to the office and they have forgotten half of their questions that they had. They say, oh, I know I was going to ask you something and I forgot. So make sure you have a diary or something where you're writing it down, so when you sit with your provider, you don't forget the important questions that you needed to ask them. Ask for second opinion if you're not improving, or ask to see a specialist, and be an advocate for yourself and your loved ones. And I think we're now going to go over resources about the lung disease. So you can go over to American Lung
Oh,
Association website.
oh, Dr. Cable, I can take the
Yes.
lead on that. Thank
Oh,
you so
perfect.
much.
Awesome. Thank you.
Absolutely. So the resources available through the American Lung Association, if you haven't been to lung.org, which is our main webpage, I really encourage you to. Whether you're looking to understand your lung disease, quit smoking, or learn more about clean air, the American Lung Association's website can help you find the information that you're looking for. You can also find downloadable forms like the getting ready for your next office visit, kind of what Dr. Cable alluded to, organizing your thoughts. This is a great form to help you prepare, as well as if you're looking for a copy of an asthma action plan, you can find it on our website. And not only do we have information and resources for people living with lung diseases like asthma or COPD, we also have a lot available for people living with rare lung diseases like IPF, bronchiectasis, EGPA, and aPAP. Just two examples include of how we highlighted different information on our website. For EGPA, we created a tracker to help people understand their treatment options, as well as um, noting down their side effects or symptoms. And for aPAP, we're really encouraging people to talk to their healthcare provider if they're finding their current medications and treatments aren't working. And so there's a lot of ways to be involved at the American Lung Association, and we really encourage you to join us in our efforts to make the world lung disease free. So, one of the ways is by sharing your story. And not only do storytellers help others feel not alone living with lung disease, but your story can also offer inspiration and provide support to others. Storytellers also help us improve our resources so we're able to better support people living with lung disease. Some of the support programs for people living with lung disease include the Lung Helpline. The lung helpline is staffed by respiratory therapists, registered nurses, and tobacco cessation counselors that can answer any of your lung health questions. Also, if you're diagnosed with asthma or COPD and looking for more support and education about how to manage the lung disease, when you contact the helpline, ask about our Lung Health Navigator program. Our lung health navigators are passionate about helping you understand how to manage your disease and will take the time to answer your questions. We also have Better Breathers Clubs, which are in person or virtual support groups led by volunteers who offer ways to help patients manage their lung disease. And also, you'll get support from others. And then we have the Patient and Caregiver Network. The PCN, or Patient and Caregiver Network, is an online support program that provides direct access to lung disease management tools, provides educational opportunities like webinars, and also a connection to others. And we also have Living with Lung Disease Inspire communities. We offer about 12 different American Lung Association online support communities through Inspire. And this is just another way that you can connect with others living with lung disease. And again, we would like to thank our sponsors, Savera, AstraZeneca, and GSK. But before we jump over to the Q&A, we'll also be putting a link in the chat to get your feedback on today's webinar. And so after the Q&A, I encourage everyone on today's webinar to take a few minutes and fill out our brief survey. Your feedback will help us improve our future webinars. And so now I'll turn it over to Jen, who will lead our Q&A.
Thanks, Nicole. And thanks, Dr. Kable, for hanging with us while we get back to the Q&A session. We had several questions come through with the registrations, and I'll get us started right away. The first one is, I was misdiagnosed as having asthma for 3 years until sputum cultures and a CT scan showed I had bronchiectasis. Wondering how common that is.
I must say that it is fairly common. I think, all depends on when you were referred to a specialist and when somebody decided to do a CT scan of the chest, because typically we find bronchiectasis on the high resolution CT scan. So that's a very important point there. If you do just a regular CT scan of the chest, we can miss bronchiectasis also. So it has to be a high resolution CT scan of the chest, which means it's very small, thin cuts of the images that we're taking through the chest cavity or through the lungs. And it is done in prone position. So it gives us very in-depth view of the lung. So yeah, I hear that very often. Typically for bronchiectasis, I would say if anyone is coughing up sputum, and they have daily sputum production, and they've been doing that for, say, 3 months in a year for 2 consecutive years, that's a definition of chronic bronchitis. But if it's happening on a daily basis, you have some sputum production, that's where you will get alarmed and to make sure that you don't have bronchiectasis. And in many cases, we don't know if the infection came first or the bronchiectasis came first. But we do believe that there's, we have all heard of cystic fibrosis. So that causes bronchiectasis, but that's a genetic disorder. And then there's something called non-cystic fibrosis bronchiectasis, where a lot of the time there might be chronic infections going on. NTM is one of them, Pseudomonas is another one. And there's many others that could cause chronic destruction of the bronchial lumen, and that causes the airway wall to be destroyed, and it makes it pouchy, makes it harder to get the secretions out, and they're thicker, and they get stuck in the lung, and they cause more and more damage in the lung. So yeah, I think I do think what you are saying is the 3-year delay in diagnosis. It is actually very common to see.
Okay, thank you. The next question, if I have asthma most of my life, does it mean I will develop another lung disease such as COPD later in life? Or will it also mean I have a higher risk of developing something more?
So I would say this is actually one of the great questions that I saw come through. If asthma is poorly treated, and if you don't take your medications on a regular basis, I see that all the time. We prescribe inhalers, they're expensive, or patients don't remember to take them twice a day, whatever that might be. Untreated asthma can lead to chronic bronchitis. And then chronic bronchitis falls under COPD. It wouldn't lead to emphysema or anything, but it will cause. So, by definition, asthma is a reversible lung disease, which means you take an inhaler, it opens your lungs up, and you don't have structural damage within the airways. But if it's untreated or poorly treated, it's going to lead to thickening of the wall of the bronchial lumen, and it's also going to lead to some airway remodeling. So the lining of the airway will become thicker, and some scar tissue is going to develop over time, and that would mean the reversible obstruction at that point becomes irreversible. And that's the definition of chronic bronchitis, is where when we do the lung function testing, we don't see it going back to where it should be. Because most of us, when we do the lung function testing, our lung capacity should be 80% of what it should be for our age group. Everyone is going to have different lung capacity for the age group or airway sizing. So we look at that. So yes, it's possible that if you don't treat asthma properly, it could lead to chronic bronchitis or chronic asthmatic bronchitis. Now, could you develop something else besides asthma? Not unless the asthma diagnosis was wrong. Like we know that from literature that with EGPA, same thing happens is adult onset asthma. 10 years later, we have symptoms of EGPA and it doesn't get diagnosed. It could be a 3 to up to 10 years delay in diagnosis. On the other hand, when looking at the pulmonary hypertension, same thing. First time when the pulmonary hypertension patient shows up, usually they get initially diagnosed with asthma. And then when we do the echo and all that, and they end up seeing the cardiologist. So there's a delay of 3 years before they actually see a specialist that treats pulmonary hypertension. So if for rare diseases, that's really a very common delay, is where you have about 2 to 3 years delay.
Okay, thanks. We also had some questions coming in the chat, and so I'm just going to add in some of those. One of them is, can hoarseness be a symptom of any of these diseases, or especially EGPA?
It can be if it's affecting the upper airway. So the way we look at the upper airway, that's your sinuses, your back of your throat, and then it's going into the larynx, which is the voice box, and then into the lung. So the upper airway are considered, which is up here, is considered the extension of the lower airway. So if you have voice changes, if you have hoarseness, yes, that could be something we would look into. Could there be other reasons for hoarseness? Yes, like, vocal cord damage, or if the nerve that supplies the vocal cords isn't working right, if somebody had thyroid surgery and the nerve is paralyzed, that's going to cause hoarseness. If you smoke, and that can cause laryngeal cancer or thickening of the vocal cords, and that can cause hoarseness. So yeah, it could be a sign, again, it's one of those symptoms that's vague and that needs investigation to know why it's there.
Makes sense. And then someone else was asking, is hypersensitivity pneumonitis a rare lung disease?
I wouldn't call it as rare as we have talked about with aPAP is like really rare. I don't know the statistics on that for HSP. I see that commonly in my pulmonary practice because we see people that have either had birds or, organic dust exposure, or they work in their yard or and stuff. So we see HSP pretty commonly, I would say, from pulmonary standpoint. For primary care physicians, maybe, but not from pulmonary standpoint.
Back to some of our questions that came in when folks registered. We have, can you have COPD and pulmonary fibrosis? My mom was put on a triple therapy for shortness of breath, yet is now being diagnosed with pulmonary fibrosis.
So there is a condition called CPFE, which is combined pulmonary fibrosis with emphysema. Now, CPFE is not the same as IPF, which is idiopathic pulmonary fibrosis. CPFE is a condition that happens in smokers where with smoking, typically patients are going to get emphysema or chronic bronchitis. But in some subset, we see fibrosis going on as well. And so I'm not, again, I don't know her full history, so I don't know if this is they diagnosed it, they labeled it as CPFE, which is combined pulmonary fibrosis with emphysema, or this is IPF, which is idiopathic pulmonary fibrosis, which is by definition typically is a progressive disease, unknown cause of the disease, and is treatable with the pills. So not curable, but treatable.
Okay. And next question, do these rare diseases respond well to biologics and steroids as they would for asthma?
So EGPA, yes, EGPA does have, a couple of biologics are approved for EGPA. Actually, AstraZeneca and GSK are the ones that have the biologic. Each one of them have a biologic that's approved for EGPA, and the patients do respond really well to it. But then again, you have to see a specialist to decide what treatment regimen works best for you.
For years, my pulmonary doctor has been convinced that I have vocal cord dysfunction, but when examined by ENT, that doctor says no. I agree with my pulmonary doctor because of my symptoms. What can I do?
So, vocal cord dysfunction by definition is not a anatomical disorder, which means if somebody looks at it, they're not going to see a problem. It's a more like a physiological disorder in the sense how the vocal cords open and close. It's an issue. Usually it's treated with speech therapy, right? ENT won't do anything for it. It's usually a speech therapist. They work with you to see to help with the vocal cords. I would go with your pulmonologist. I would go with you if you feel like, that's where you're at and your symptoms have improved with the treatment. With speech therapy is typically what we do. And that's what you go. If you had vocal cord paralysis, then the ENT will see it. But vocal cord dysfunction is usually symptom based. You'll see voice changing over time. You'll be short of breath when the voices change. And it gets back to normal sometimes and it goes back to bad other times. So yeah, it's just a dysfunction of the vocal cord. Vocal cords themselves are okay, but they're dysfunctional.
Okay, thanks. I'm going to go back to some of our questions coming in the chat. Who is the best type of physician to treat PAH, or would it be a combined approach?
So 90% of pulmonary hypertension is treated by a pulmonologist. Only 10% of the cardiologists treat pulmonary hypertension in the US. And part of that is for when you talk about the pulmonary artery, it is actually the vein that's basically deoxygenated blood that's going into the lung, picking up the oxygen, going to the opposite side. And so the oxygenated blood is actually in the pulmonary vein, and deoxygenated blood is in the pulmonary artery. And so even though it's connected to the right side of the heart, it's an internal problem with the pulmonary artery itself. If it is true PAH, because there could be pulmonary venous hypertension, there could be, pulmonary hypertension due to lung disease, and there's a gamut of things that can cause high pressure in your pulmonary artery. But yeah, it's usually a pulmonologist that's going to know more about the lung diseases that can cause pulmonary hypertension, sleep disorders, so 90% of the time it's a pulmonologist that's going to treat pulmonary hypertension or even do a right heart cath. Because again, that's more of a venous circulation, even though it's pulmonary arteries, what we call it. It's a deoxygenated blood.
Okay, thanks. We'll try and get two more questions in here. The first one, have you seen or heard of any pediatric patients that are diagnosed with these rare diseases that we've been talking about today, aside from asthma, the common disease?
Usually, so let's talk about one at a time. So pulmonary hypertension can happen with congenital heart diseases. So if a baby or kid is born with congenital heart disease, they could have pulmonary hypertension. aPAP, not as common that I know of. However, I'm not a pediatric pulmonologist, but aPAP I've not heard of in pediatric population. As far as EGPA, usually it's an adult onset disease. So I'm not aware of EGPA in children as well. So.
And then the last one, I know you touched on this a little bit, but maybe just looping back to it. My primary provider doesn't want to refer to me to a specialist, but I think I need one. What can I do?
I guess I would say, engage with your primary care physician, ask them why they don't want to refer. Because typically, if a patient asks me, hey, can I do a second opinion? Can I go to, so and so? I say, sure. Because to me, it's important for patients and I to be on the same page. So I think I would maybe ask them why they're not wanting to refer. Most of the time, if you have a PPO plan or a insurance plan that does not require a primary care referral, you are able to see, you call the specialist and you are able to see them. But I feel like, the primary care physicians are like they're the captain of your ship. So getting them involved is important. So you have a trust built with them. So they don't feel like you are kind of, don't trust them. But in the end, sometimes you have to do that. I have had patients that will just self-refer. They'll call and they'll make an appointment. So I think it depends on the relationship and figuring out why is that the PCP or primary care physician does not want to refer you.
That's good advice. And I think it helps to think about having those conversations, sometimes tough conversations, but yeah, having those conversations with your provider and working together as a team. Wonderful. Well, thank you so much, Dr. Kable. We really appreciate you joining us today and sharing all this wonderful information with us, and definitely getting us thinking about how we can work with our healthcare providers and be advocates for ourselves and what to do in that regard. So thanks so much. And I also want to thank everyone that was able to attend today's webinar. And as Nicole mentioned at the start, you can access the recorded webinar from your registration, and we will be following up with an email as well, and we'll have a link to that as well as the survey. If you were able to do the survey, Nicole did put it in the chat to grab that as well, so that we can continue to offer webinars that meet the needs that you're looking for. So thanks so much, everyone, for joining us today. We appreciate you coming.
Thank you, everyone.